Hello and a very, very warm welcome to today's webinar, MND 101. Our presenter today is Elizabeth Krask and I'm your facilitator, Nicola Graham. And we like to start all of our programs with an acknowledgement to country. So we acknowledge and pay respect to the traditional custodians, past and present, on whose lands we meet today. We acknowledge the deep feelings of attachment and the relationship of Aboriginal people to country, and we respect the cultural authority of the elders in each community. So it's with great pleasure that I introduce our presenter today, Elizabeth Krask. Liz has worked in the aged, disability and neurological disease areas for 23 years now. Elizabeth works at MND Victoria as a MND advisor and a team leader, and she's been at MND for 9 years. Prior to working for MND, Liz worked for Dementia Australia as a counsellor for 14 years, and Liz has a Bachelor of Social Work and a Bachelor of Education. So just a note there regarding informed choice, and we'll now change screens so that you can see Liz's screen, and Liz will take over the presentation from there. Thank you, Liz.
Hi everyone, my name's Elizabeth Krask, and thanks for that introduction, Nicola. Thanks everyone for attending the seminar today. Please feel free to ask questions along the way, and if there's any questions that you don't get an opportunity to ask, you can forward them to Nicola and she'll pass them on to me and I can answer them that way. So the overview of the session today, we're going to talk about what is MND. We're going to go through some of the different phenotypes or the main phenotypes. We'll look at some interventions and practice considerations in managing MND. We'll talk a bit about the complexity of the disease and the multidisciplinary care that's provided to people with MND. And we'll also just look briefly at the palliative care support that's an integral service for people with MND, and just a few of the main resources that people with MND access. I'm going to turn my video off now and start the presentation. And throughout the presentation, we'll do a couple of polls where Nicola will ask you a question and you get the opportunity to fill in the answers. So what is MND? Motor Neurone Disease is a progressive degenerative neurological condition. And what that means is the changes that are occurring to people with MND are coming from the brain. There is no cure for motor neurone disease, and they do not know why people get it, but many of the symptoms can be treated. It is a life-limiting disease. The average survival is between 1 and 5 years from diagnosis to death. But then some people will report that they've had symptoms for many years prior to getting a diagnosis. There is no remission with MND, unlike some other neurological conditions. So once a person has a functional decline in a particular area, that area of function is not restored at any time. And it tends to be a steady progression. So it will continue, the people may go through periods where they seem a little bit more stable, but there is deterioration going on the whole time. So right now there's approximately 2,000 people in Australia with motor neurone disease. The most common age group is people in their 50s to 70s. But in saying that, we've had clients as young as 18 or 19 years of age at diagnosis, and we've had clients that are diagnosed in their 90s. The most common is in your 60s. So they believe that age is a part of the condition. There's slightly more men than women, so the ratio is about 60% men, 40% women. And every day, two people die with motor neurone disease every day. The incidence, or the new cases per year, is approximately 2.65 per 100,000, and the prevalence, or the amount of cases in total at any time in Australia, is 6 to 7 per 100,000. And in Europe, the prevalence is 7.9 people per 100,000. There's no indicators that MND is a disease that is stronger in any particular part of the world. You know, there might be slight differences in the prevalence, but not much. And the prevalence of men to women is 3 to 2. And these are just this slide just shows a few facts about MND. Over the past 5 years, the pace of research into MND has really accelerated and transformed the understanding of the disease. But in saying that, they understand more what's happening, but they still don't understand why it happens. And there's 1 in 11,434 Australians have MND. So the suspected causes. They feel that MND is a combination of things that occur. So it's genetics, and a lot of the research is finding more and more genes that are associated with MND. And if you look in the yellow, in the circle, the ones with the C21ORF2, the MOBP and the SOD1 gene and the NECI1, they can all be, they're all associated with the sporadic MND, which is basically anyone can get it. So that's 90% of all cases are sporadic. But we can test for those genes and see if the person has them. But they think it's also, you know, but people can have those genes and they don't go on to develop MND. So they think it's other factors like environmental factors like exercise. And in the exercise, interestingly, it's people that over-exercise. So I've had many clients over the years that are extremely fit and do, you know, cross-country skiing. They'll run 10 kilometres a day. They've always done very physical jobs, and they're actually fit, healthy people, and then they get MND. So the exercise, you know, they think that somehow this this really high level of exercise in some people can trigger the disease, but they also have other factors that are impacting on it. Smoking, chemicals, toxins, blue algae, there's lots of areas in the environment that they're researching. I had one client years ago who worked in a radio room, you know, with radio, electronic radios. And there was 3 of them that ran the business. 2 of them got MND and the other person didn't. So there was obviously other factors going on for those 2. They also feel the aging process has a lot to do with it because the average age of onset is 50 to 70 years of age. So it's a complicated disease like every neurological condition. 10% of cases of motor neurone disease are familial, which means that there is a genetic association. And then you can see those 5 top genes are the ones that can be tested for motor neurone disease. So if someone has symptoms, they have a family history of it, they can test and see if they have those genes. If people have a family history of motor neurone disease, they can be tested and see if they have those genes. That doesn't necessarily mean they will get MND, but it means that they certainly have a much higher risk of getting it. And a lot of people do choose not to have the tests if there's a family history. When there's a family history, it's usually fairly significant. So it doesn't tend to skip generations, and it might be that, you know, there's aunts, uncles, grandparents, cousins, you know, quite an extensive family history of it. And then the other symptoms as well are still in play with people that get a diagnosis. So first symptoms. People report many different things that they notice initially. And often these symptoms can be subtle, like, you know, I couldn't do up the buttons of my shirt, I had difficulty swallowing and started to have some coughing fits, I felt a bit short of breath, my speech became a little bit slurred, or I lost a bit of weight and I didn't know why. But often the initial symptoms can be subtle, and people may simply just feel more tired and that they're slowing down because they're getting older. So often when people go to their doctor, they don't actually think of themselves as being unwell. So the diagnosis can come as a real shock to people. The diagnostic process is one of ruling out other conditions. So there's no definitive diagnosis for motor neurone disease. It can be long, slow and frustrating. There's lots of tests that rule out other conditions. So they'll do a CAT scan of the brain or the spinal cord to rule out strokes or tumours. They'll do a myelogram where dye is injected into the spinal canal to exclude tumours or pressure on the spinal cord from some other sources. They'll do an MRI to exclude multiple sclerosis. They do blood tests to exclude a variety of other neuropathies. There is no blood test that can confirm motor neurone disease. They might take a muscle biopsy to look for denervation and thinning of the muscle fibres. And they do electromyography or EMG, and that's to measure the electrical activity in the muscle and how well the nerves conduct the signal. And remembering that motor neurone disease is the deterioration of the nerves that control our motor movement. So often they will do a series of tests, and the electromyography one is the final test that they usually then conclude. If that shows up changes, then they'll start seriously looking at motor neurone disease. It is a diagnosis by exclusion, and you know that's why it can take such a long time for people to get the diagnosis. And obviously it's not one that is given out easily either. They want to be pretty sure that that's what it is, and it does require a specialist neurologist. So while some people may go to their GP and the GP may think it's MND, you would get a specialist neurologist to diagnose it, and then usually they get a second opinion as well to make sure that that's what it is. And as I mentioned before, the shock of the diagnosis is often enormous to most people. A lot of people have actually never heard of MND when they get a diagnosis. So Nicola, you can launch the first poll now, which is, which of the following statements is accurate?
Okay, great. So if you could all just vote on what you think, select one. MND is diagnosed by a single test. MND is uniform in its presentation. MND is likely to be caused by environmental factors only. There's no definitive diagnostic test for MND, and MND affects your senses. So I can see people have hopped on really quickly. 60% of people have already voted. I can't see who makes what vote, so it's totally anonymous, so go for your life. And we've just got a few more people to vote, so I'll just give you a couple more moments and then we'll close that poll and share the results. So we've got 80% of people have voted. Okay, a few more people and we'll close that poll now. That's great, thanks guys. So just sharing the information there, all the results there. We've got 100% of people have got the correct answer. There is no definitive diagnostic test for MND, so that's great. People are listening and attentive, Liz.
Thank you. Okay. So this slide shows you the difference between a healthy neuron or nerve cell, which is the one on the left, and the damaged one from the one on the right. They believe that 70% of the damage has already occurred by the time people experience symptoms, which is just shows you how remarkable the human body is. The death of motor neurons is a normal part of the aging process, but with MND, it happens at an abnormally rapid rate. It's unknown if the neurons are lost over a long period of time or if they're lost in a sudden catastrophic event. And research is looking into all of those sorts of things. So when the nerve cells die, they're not sending the messages to the muscles, and the muscles then waste away and cease working. And the muscles that are affected by motor neuron disease are movement, so that's our arms and legs, the bulbar group of muscles, and that's in your throat that controls speech and swallow, and the respiratory muscles. And when I say the respiratory muscles, there's actually nothing usually wrong with people with MND with their lungs. It's the muscles that push the air in and out of the lungs just weaken and weaken until they experience respiratory symptoms. So it's those 5 areas of voluntary movement, of voluntary movement that's impacted by the motor neuron disease. These are the 4 main phenotypes. So the most common form of motor neuron disease is amyotrophic lateral sclerosis, or ALS, and that's 65% of people have that. And this is a limb onset. So it starts in either your arms or legs. Oh, there might be hands and then go up to arms, but upper limbs or lower limbs. And in this particular type of motor neuron disease, the upper motor neurons, which come from the brain stem, and the lower motor neurons, which come from the spinal cord, are involved all the way along the disease. The next type is progressive bulbar palsy, and this is the one that starts in the bulbar muscles of the speech and swallow. And this is another form of MND that has both lower and upper motor neurons involved. And usually people first notice with bulbar onset that their speech is affected. So their voice may become quieter, or their speech becomes more slurred. The swallow mechanism is more automatic, so that tends to be damaged later on. It's the speech that's usually damaged first. And the third phenotype is progressive muscular atrophy, or PMA, and this one is lower motor neurons. It's a slower form of progression, so people can live for over 10 years with this one, and it tends to present as flail arm or flail leg. So I've actually never seen anyone with flail leg, but I've had clients with flail arm. So for many years, their arms just have no functional ability whatsoever. Now, over the course of time, people with this flail limb variety will still experience the other symptoms, but it takes much longer. And then the fourth phenotype is primary lateral sclerosis. And this is where it's mainly upper motor neurons are affected. So people experience a lot more sort of spasticity and contractions. It's very rare. It's difficult. It's only about 1% of people with MND. And it can take over 4 years to diagnose, because people can have different rates of progression with MND. And initially people might think it's very slow, but they would not diagnose primary lateral sclerosis without observing someone for at least 4 years to ensure that it really is very slow and not any other form. So with the PLS, it often affects usually starts in people's legs, then it's followed by trunk weakness, arms, hands, finally the bulbar muscles, and then the respiratory symptoms. And with this particular type, they're often quite stiff, like their muscles are stiff and spastic, and so often they can't walk, can't carry out a lot of tasks, and their fine motor coordination's really impacted. And they often have a lot of difficulty with balance, and have a lot of falls. So they're the main phenotypes that we talk about under MND. There is also Kennedy's disease, which is known as X-linked spinobulbar muscular atrophy. And as an organisation, we support people with Kennedy's disease as well, because the symptoms are very similar, and eventually people will experience all the symptoms of MND. This is a totally genetic condition though, and initially it only involves, and for a long time, only the lower motor neurons. So people tend to be floppy. They have that floppy muscle and lack of reflexes. It's a genetic disease that is carried by the female side of the family, but it only presents in males. So the women are the carriers, but only men will develop the disease. So if you had, for instance, your father had the disease and you're a daughter, you could be a carrier of the disease, but you won't contract the disease. But then your daughter could also be a carrier. So it's got complex genetics, and I've over the years worked with various members of one family that have had it. And people can often be diagnosed with this at a young age. They might be in their 20s. It will, people with Kennedy's disease will go on to experience all the symptoms of people with motor neurone disease, but it's much slower, and it doesn't often shorten their life in the same way that MND does. So some clinical signs of motor neurone disease. As I mentioned, it affects our movement, speech, swallow, and respiratory function. So these are some of with the upper motor neurons being damaged, so they're the ones that come from the brain cell. People experience muscle spasticity and stiffness. They can experience hyperflexion, where the reflexes extend beyond normal limits. They can have extensor plantar response, which is where the big toe bends up and back onto the top of the foot, and then the other toes fan out. And obviously that sort of reflex can really impact on people's mobility. They can have ankle clonus, and that's where the foot sort of extends forward or extends right back, and often it can become contracted in that position. Physical therapy can assist that, and certainly physical therapy needs to be implemented before it really contracts, because sometimes these contractions can just remain like that. In some extreme cases, some people do find relief having Botox treatment for some of these contractual situations as well. And another symptom from upper motor neurone is a Pseudoburber Effect, or emotional lability. And this is where people lose the ability to control the emotions of laughter and crying. So they may start laughing and then they can't stop laughing for way beyond whatever was humorous in the first place. Or they may likewise start crying and then they can't stop crying, and then they get into a really distressed state. And the other interesting thing about this trait is that they can also cry instead of laughing and laugh instead of crying, and they have no control over this at all. I've had clients who, you know, it's quite severe and they're concerned about going to things like funerals in case they start laughing. One of the treatments for that symptom that's effective for some people is a cough medicine. They don't know why, but they do know that it does calm that down in some people. Some of the clinical signs of lower motor neuron involvement is muscle wasting, muscle weakness, that sort of floppy muscle, fasciculations, which are muscle twitching and contracting. And sometimes people have that, they'll have the fasciculations all up and down their arms, and you can actually see their skin jumping if it's quite significant. And then absent or depressed reflexes. Other clinical signs. With speech, people have dysphonia, which is their voice becomes very weak and soft. They can have dysarthria, which is like a slurring of the speech, and that's often a very first symptom for people that have the bulbar onset. They can have dysphagia, which is an inability to find the right words and put the words in order. And they can experience anathria, which is where they really have no speech at all anymore. They can often still make sounds, but there's no speech. People have swallowing changes or dysphagia, where increasingly it becomes difficult for them to swallow, and their diet will change. They will go on to, you know, they tend to start with eating smaller amounts and cut the food up really finely, to a minced diet, to a soft diet, and in some cases people have a peg feeding tube and get all their nutrition that way. Saliva becomes an issue for people that have significant bulbar symptoms. So we actually automatically swallow about 1.5 litres of saliva every day. That's how much our bodies produce. And so if you are having swallowing difficulties, that is a lot of saliva to manage on a daily basis if your bulbar muscles are not allowing you to automatically swallow that saliva. People tend to have Clonus, it's a bit hard to say, and that's an excessive saliving and drooling that accumulates in the mouth. There is medication that can assist to dry that up, but it's a fine line because you don't want to get a really dry mouth as well. And for some people, that's not effective. In extreme cases of that excessive saliva and drooling, people do have Botox treatments, but that leads to other complications, because when you inject the Botox into a muscle on a continuous basis, that will weaken that muscle, and you've already got the muscles weakening with the MND. And then the other exorostomia is when people have thick, sticky, ropey saliva, and it often feels like there's something stuck in their throat. And they often get quite a dry mouth with that type of saliva as well. There is various different things that you can try. When people have the thick, ropey saliva, the approach is to try and wash it down rather than expel it, because of all the other muscle changes. Trying to expel it is exhausting for people, and it's not successful. But, you know, people tend to have dry grape juice and pineapple juice because the enzymes will break up that saliva. They use nebulizers, and there is medication that people can have prescribed as well. And there's lots of artificial salivas that people can use now to address the dry mouth. And then respiratory symptoms. People with MND usually die of respiratory failure. So once the respiratory symptoms start to occur, then we know that people are moving into a different phase of the disease. And for some people, the MND is respiratory onset. It's not very common, but some people, that's how it starts. They actually have changes in their respiratory function. So what happens when people get the respiratory symptoms is the muscles weaken and they are unable to expel the CO2, which builds up, and then they just get more and more tired. They wake up with headaches, they have less and less energy, and the breath just gets shorter and shorter. And people also experience orthopnea, which is an inability to sleep lying flat. You can launch the second poll. Thanks, Nicola. The one, which of the following is not a common symptom?
Great, so you should all be able to see that now, and your options are loss of fine motor skills, slurred speech, loss of continence, swallowing difficulties, and spasticity in the limbs. So I can see people are getting the hang of this now, and a lot of people have voted already. As I say, it is anonymous, so just have a go. That's great. Okay, I'll just wait a little bit longer so I can get some more votes in, and then we'll share the results. Okay, got about 80% of people have voted, so have a go. Fantastic. Okay, just going to close that poll now and share the results with everybody. So we've got 83% of people saying loss of continence is not a common symptom of MND, and some people have said spasticity in limbs is not a common symptom.
Okay, so the correct answer is the loss of continence. People with the upper motor neuron symptoms experience spasticity of their limbs. So that stiffness and spasticity is caused by the decline in the upper motor neurons. Continence, the involuntary mechanisms or organs like our heart and kidneys and liver, our bladder and bowel are not affected. You know, those muscles don't weaken as a part of the weakening of they're not the muscles that are affected by the motor neurons. However, people do develop continence issues because for various reasons. When they're in the more advanced stages of the disease and they have global weakness, that can affect their ability to manage their continence. And often people can't recognize, you know, as their muscles weaken all over, they can't get to the toilet. You know, there's continence issues for many reasons, and often it's around not being able to get to the toilet in a timely manner. In a very advanced stage, continence is often an issue, but it's not a symptom of the motor neurone disease. It's more of a side effect, I suppose you could say. So changes in cognition, behaviour and language. It was felt for a long time that motor neurone disease did not affect people's cognitive ability. However, now they understand that it does. And up to 50% of people with motor neurone disease may experience changes in their cognition. The usual changes are around the thinking processes. So that's often, it's from the executive function of the brain, which is our frontal lobe. So if you put your hand from your eyebrows back on the front of your head, that is the frontal lobe of the brain. And that tends to be the executive function, and it's about decision making, concentrating, thinking, problem solving. It's those sort of functions. So those type of functions can be impacted. Our temporal lobes manage our language. So the changes in language tend to be around choosing the right word, putting sentences together in a correct manner, and just having general word finding difficulties. And people can become very repetitive, so they just say the same statement over and over again. Social cognition can change. That tends to be a frontal lobe function. So people may be impulsive, they can say inappropriate things to strangers. They often also have an inability to read emotions in others. So they won't recognize if you're upset or why you're upset, and they tend to really lack empathy. And then there's also behavioral changes, so impulsiveness, rigid thinking. People can be very apathetic and have no energy. They don't want to get up, they're not motivated, and they can behave inappropriately. So they can yell out, they can make inappropriate comments. They don't understand why they can't do a particular thing, and in some cases people can behave quite aggressively. So often it feels like the personality of the person has changed when they have these cognitive changes. As I said, up to 50% of people experience the changes, but in the majority they're relatively mild, and while they can have some impact on their day-to-day functioning, it's not enormous, and they'll be diagnosed as having ALS, frontotemporal spectrum disorder. For about 5 to 15% of people, the cognitive change is a lot more significant, and they will be diagnosed with a frontotemporal dementia. In some people, their first symptoms are that frontotemporal dementia. And if you remember the genes that we looked at that are associated with MND, what they've discovered is the COL72 gene is a gene that's also found in people with frontotemporal dementia. So they've made this strong connection between MND and FTD. It's not to say people with frontotemporal dementia are all going to get motor neurone disease, and it usually does occur the other way around, but sometimes people do present initially with the FTD symptoms. They can be very difficult to manage, these people. There's no medication to address FTD. It's usually a behavioural management approach that's taken, and family and people around the person being educated and understanding how to manage the person. And usually it's neuropsychologists, the practitioners that develop the management of FTD and the behaviour management programs. And they'll work with the person and with their family. So you work as much with the family as you do with the person. And look, if there was extreme behavioural issues, then there is medication that can be prescribed to help manage them, but it's not, it tends to be a symptom management approach with this. Motor neurone disease has a significant emotional impact on the people that are diagnosed. Many people experience anxiety, fear, depression, and a great sense of loss, and that can be throughout the whole disease and from the beginning of their journey as well. And certainly when people start to experience respiratory symptoms, anxiety can usually come with that because it's quite frightening. And MND doesn't just affect the diagnosed, you know, it's a very difficult disease, and it affects the family, friends, colleagues, workers. It affects everyone. And even people who work in the sector can be significantly impacted on working with people with motor neurone disease. I think, you know, one of the toughest things being a worker in the area is that when I meet my clients initially, they're usually relatively independent and have not a great amount of functional loss or disability, but in a very short period of time, that can all have changed dramatically. And that's challenging for everyone, but certainly the most challenging for the person and their family. Motor neurone disease has often been referred to as a disease of losses, and this includes things like, obviously the loss of a person's function, their mobility, their voice, their independence, their future dreams. For many, it's a loss of their identity and a loss of their role of, a husband or a wife who becomes their carer. One becomes the patient, one the carer. A loss of the role of a parent. There's a lot of those tasks that people can no longer do. And a loss of career. There's not very many people that are diagnosed with MND that continue to work for very long. And that can be, often they're not able to, but also they often choose not to because they know what lies ahead, and it just doesn't become, it's not a greater priority for them anymore. So what makes motor neurone disease complex? Obviously the speed of the progression, and also pre-existing medical conditions. We must never forget that people with MND also get other things wrong with them or have other health issues. It really brings to the fore any other family issues, whether that be the health. I've worked with many clients who get diagnosed with MND who've actually been a carer of their partner, and then they get MND and they need a carer, and often their partner is not able to provide that support. The impact of cognitive change is enormous on people. There's a lot of social issues associated with MND that makes it complex. People don't want to be seen as disabled. They don't want to, particularly when they have bulbar symptoms, they don't want to often go out in public. Housing is a big issue. People with motor neurone disease cannot often remain in their own home because it's not suitable to meet their needs. It might require significant modifications that they're not able to carry out. Unless a person is on the National Disability Insurance Scheme, and that's people 65 or under, well, under 65 when you go on the scheme, unless they have a carer, they often will end up in some sort of disability accommodation or an aged care facility because of the amount of care and support a person with MND requires. If they don't have a carer and they aren't able to access that level of support the NDIS provides, they're not likely to remain living at home. And geographical isolation is also an added complexity because people require a lot of support. They require a lot of allied health input, and if they live in an isolated situation, that support is often not available to them. Social isolation can be a big thing for people with motor neurone disease. Some people may have pre-existing psychological disorders which really impact on their ability to come to terms with and manage their motor neurone disease. If they have the cognitive change, that's an added complexity, and if there's other issues in their family, then that makes their situation very complex as well. It's important that people plan ahead with motor neurone disease. It's a very individual disease. It affects different areas of the body for each person. It'll progress in different patterns and progress at different rates. So there's no recipe for managing MND. And a lot of these changes, we can have an idea of how they're going to play out, but we can never be certain. There's no set pattern of the disease progression. So we have to treat every person with MND individually. no two people are going to have exactly the same disease process. And the needs of people are complex, and the symptoms can progress rapidly, which leads to an escalation in the level of care needed that's often not supported by what's available. And it is important that people with MND have a range of health professionals involved and have regular assessments and review of their changing needs. So people often don't know what they don't know. MND is a hard diagnosis to come to terms with. And unfortunately, forward planning is essential. And often people are so distressed by the diagnosis that they can't think of what lies ahead. And as I said earlier, many people have never heard of motor neuron disease, and if they have a very limited understanding of what the disease is about and what lies ahead. And people may think, you know, in the earlier stages, the symptoms can be subtle, and people may think that, oh, look, I'm okay, I can manage this, this is how I'll be. But, you know, the level of change can be extremely rapid. You know, in 9 years, the most rapid experience I've had is a person who was 6 weeks from diagnosis to death. And that was, even the neurologists were shocked by it. People with motor neurone disease talking about 5-year goals, it's not usually appropriate. So things to consider for the person with MND: they may be in denial or ambivalent about having MND. You know, I've had people that think, I've got one client at the moment, his MND, he's in his 80s, it started in his legs, and he's saying to me now, I'm just going to fix the house up and I'll sell it in the next financial year. And I'm thinking, you will not be able to mobilise around that home before the end of this financial year. So it's a very big hurdle to address with people, is that ambivalence about the disease and understanding that you don't have the time and you need to start planning now. And some people, you know, they just do not cope with that very well at all. And this was a quote from one of our clients: all the changes with MND happened so quickly, there was no notice ahead of changes. And that really does capture it. Best practice interventions is a multidisciplinary care team with symptom management. And a lot of research has gone into this and shown that this is the best approach for people with MND. Good nutrition, it's a disease of loss, and it's, you know, people need to have good, adequate nutrition. As the disease progresses, eating and maintaining weight and an adequate diet becomes more and more difficult. Non-invasive ventilation is an intervention, and the only drug on the market in Australia is Riluzole, and that can be prescribed, and that's believed to slow down the disease, but, you know, really it's an extension of 3 months basically. This is just an outline of the type of team, multidisciplinary team, that will surround a person with MND. So as you can, you know, people can have 10 to 15 workers around them that are their clinicians and support people, you know, all the time. Allied health is extremely important for people with MND. They're the ones that manage the, you know, the equipment that people need and strategies for dealing with the changes in their movement, their speech, their swallow, and their respiratory function. Good nutrition, as I mentioned, is important. Many people end up having a percutaneous endoscopic gastrostomy tube, and they receive a lot of their hydration and nutrition through this means when the swallow becomes too difficult. Also, as people develop respiratory symptoms, the fatigue can be enormous, so that combined with the difficulty swallowing can mean a meal can take 1 to 2 hours and be exhausting. So people will often have the peg feeding tube to overcome some of those things, and then they just eat orally for social and taste, but get their basic nutrition through the peg feeding tube. The other main intervention is non-invasive ventilation, and this is a ventilator that's similar to a sleep apnea machine. It just pushes the air in and out and does some of the work that the muscles are no longer able to do. It clears away some of that buildup of carbon dioxide, so people wake up feeling more refreshed and less tired. However, it's not stopping the respiratory changes, and that's still going on, and people will use the non-invasive machine more and more as the respiratory function continues to decline. And these two, the peg feeding tube and the non-invasive ventilation, tend to go hand in hand. So you would not normally prescribe non-invasive ventilation and have it implemented if somebody didn't want a peg feeding tube, because as the respiratory function continues to decline, you'll be using the machine more, and the machine involves a mask, and obviously when you've got a mask on your face you can't eat as well. So they tend to do these two interventions together. In some instances, people will have the non-invasive ventilation without a peg as a symptom management. Peg feeding tubes also reduce the risk of chest infections that can result from aspiration or food and fluid entering the lungs. So, you know, that it's beneficial from that point of view as well. Palliative care. People with MND are often deemed palliative at diagnosis because of the complexity of the symptoms. And that's another difficult thing, because we tend to think of palliative care as end of life, but in MND, it's a part of the symptom management, and particularly once people have respiratory symptoms. And, you know, palliative care help to maintain the quality of life, they support the carers, and they deliver the service in a variety of settings, and that includes aged care facilities, at home, in palliative care units, or basically wherever the person is living. Towards when the disease becomes more advanced, people often take Ordine, which is a liquid morphine, and that helps with the anxiety and the breathlessness that comes with the respiratory change. And we would certainly want to get palliative care involved at that level if they weren't already involved. And this is just a range of the services that a community-based palliative care service can offer. Advanced care planning is also very important for people with motor neurone disease, particularly as they're going to lose their speech and their hand function. They need to get all of this paperwork in place as early as possible to give them the capacity to choose who manages their affairs. And because of people going into respiratory failure, it's important to have a medical directive in place so that they have somebody who's able to speak on their behalf. Because if a person had a respiratory episode, an ambulance was called, you need to be clear on what level of resuscitation you choose to have. Voluntary assisted dying is available in Victoria, and they have the care navigators that assist people to guide them through this system. It's an individual choice. It's a difficult choice, and there's a lot of eligibility criteria. And look, if people raise it with us, we simply refer them to the care navigators. It's not something that as a worker we're able to raise with people. And unfortunately, a lot of the mainstream services don't engage with the voluntary assisted dying. So often if people choose to go down that path, they need to change their practitioners. But all of these things tie in with them having their choices, being able to decide how they want to live for the remainder of their life and what represents a quality of life to the person, which is really important for someone with MND when they feel that so many choices have been taken away because of the disease. People with MND have a lot of fear around the end of life because they are going to die from respiratory failure. And because it's such a complex disease, they want to know, can they stay at home? Where do I go if I can't stay at home? Who's going to care for me? And how will I actually die? Most people die in a peaceful way. They're usually taking medication. It is very rare, while people can have choking episodes on food and drink, because of their swallowing changes, they rarely die from that. I've not known of anybody to die from like a choking episode, but I do believe that it's happened. Most people go to sleep and, you know, they don't wake up because their respiratory function is so weak. Some people choose to withdraw the non-invasive ventilation. So if they've become dependent on it, then they choose to withdraw it, and that's done under medical supervision, and they will be given medication to put them to sleep. And often medication, as in all end of life, is used to address anxiety and restlessness. And again, I can't stress enough the importance of the palliative care team in the terminal phase for a person with MND. As I said, the most common cause of death is respiratory failure, but some, you know, secondary conditions such as aspirational pneumonia are a common cause of death for people with MND. They can, look, obviously people can die from lots of other causes as well, but usually this is the most common cause of death for people with motor neurone disease. I just wanted to, I think we're just about out of time, so I didn't do the last two polls because of the time. These are just some community resources. So this tells you a little bit about motor neurone disease. And the thing to remember too is we have an enormous equipment library, and we provide equipment for most of our clients. If they're on the NDIS, it's funded through them. If they're over 65, we fund the equipment to ensure that people have access to it, because there's no other government funding available if it's not under the NDIS. Some Victorian services, there's three statewide clinics that see people with motor neurone disease. So Calvary Healthcare Bethlehem, there's one in Belmont in Geelong that is obviously geographically based, and there's one out at the Bundoora Centre in Plenty Road, Bundoora, that tends to service people in the northern suburbs as well. There's also the Victorian Respiratory Support Service, which they provide the non-invasive ventilation. They do all the lung function testing and managing of the respiratory symptoms that people with MND experience, and they do that across the whole state. MND Care website is often really useful as a source of information for people. And I just wanted to acknowledge MND New South Wales for use of MND Aware content in this presentation. MND Aware is an online education program that you can do with MND New South Wales, and it's really good actually. It's a really good presentation. And they're just the contact details of MND Victoria.
Thank you very much, Liz. Really appreciate that. Just going to do some final housekeeping, but plenty of information there for people to consider, and with their handouts as well. So thank you, Liz. Really appreciate it. So I just want to very quickly run through some of the services and supports that are available for your clients through MS. We've got an MS Practice, which is an online education tool for yourselves, for health professionals. We're an NDIS provider. For your clients, we've got a range of podcasts and a webinar library. We've got ebooks that you can access as a webinar attendee, and your login details are there. There's a MS shop where you can purchase recordings of previous webinars, and there's an extensive library there for health professionals. Please subscribe to the Inform newsletter. That's how we send information out to you of upcoming health professional education opportunities. And our number, if you need to reach us as via MS Connect, which is the gateway to our services, is 1800 042 138. We've got a very brief survey after this webinar, and I'd love it if you could stay on and just complete that survey. And thank you very much for your time and attention today. It's really appreciated. And thanks again, Liz.